Ebola spread because that part of West Africa is a public health desert, and Ebola killed because that part of West Africa is a clinical desert. And unfortunately, we keep confusing the two.
Yeah.
And you know, if I had to speculate as to why, it would be that the dominant paradigm here was a disease control paradigm. And in fact, you could even say a disease control only paradigm. So what gets left out of control only paradigms? That's care. Basically, all efforts are to stop the spread of the disease. That means you wall off an area, shut down the clinical institutions, and isolate suspected cases and confirmed cases.
You don't actually provide any real care.
You don't provide care.
Yeah.
And even, you know, when it's a pretty frightening thing to see when you're on the inside of that quarantine barrier. It's unnerving. And that's even for people like my colleagues, my medical colleagues who died. They knew what was happening, both of them. One was a surgeon and one was an expert on hemorrhagic fevers. So to be on the other side of that, I mean, that's one of the things that pains us most, you know, is that they, like their colleagues who were nurses and doctors, were fully aware of what was going on, and that they were in Ebola treatment units that didn't have much in the way of treatment.
What do you think a good system looks like in that context?
It's a great question, and I would say principally a good system that can respond to a threat is not an emergency system, it's an everyday system that can respond to emergencies. And so an everyday system in this case would mean having an effective community health worker and I will describe to you what happened in the districts we had already had this system and where we then responded with the same approach and what happened. Having an effective community health worker means having a coach that is a nurse. If there is a nurse that recognizes that, that's wrong, that in fact, that probably isn't pneumonia even though it was diagnosed, maybe it was Ebola. Maybe it was a disease I don't even know yet or have been trained on. She's tapped into a clinic, and this all of our nurses are, that's tapped into a surveillance system. And that rings the alarm bells. Now, how do we know this could make a difference? Well, I mean, you know, we can never do the counterfactual in these situations, but we can look at observation. And in Conobo District, this area the size of Rhode Island, about 15,000 people spread out across 42 villages, some as small and some even smaller and some a few bigger than Meliandou, but same rainforest actually, exact same rainforest called the Lower Guinea Rainforest, but it's in Liberia. Now, we were able to mobilize that entire district and the county along with the government to, first of all, help keep the Ebola threat out by organizing healers and police and tribal chiefs to work on it. Nonetheless, the ripple effects from Ebola were still prevalent. Most people across the country, whether you had a high Ebola area or a low Ebola prevalence area, stopped going to clinics. As I mentioned to you, the facility-based delivery rate across the country dropped threefold. In Conobo, it went from 82% to 79%, it dropped 3%.
It just stayed about the same.
Stayed about the same, and that's because these health workers were doing Ebola screening. The perceived threat of Ebola was still there, but they put hand washing stations in. They were able to educate their people. They knew what the disease was about. They were professional about it. They knew the difference between that and malaria. They even set up a system, and this is probably one of the most profound things we observed, where they were able to still keep childhood causes of fever treated.